The ACC produces appropriate use criteria in a variety of different areas. Today we're taking a look at trade-offs in appropriateness of PCI. So controversy abounds here, I hope not, but it could be. I am with Dr. Karen E. Joynt, MD, MPH, Brigham and Women's Hospital and VA Boston Healthcare System. And this is, by the way, a Jack commentary, and it was a commentary relating to another paper. Can you talk about that paper first, and then we'll talk about your opinion of same?
Absolutely. So I think what we have thought had been happening before with PCI, so take a step back before the appropriateness criteria. There was a lot of focus on underuse of PCI. Correct. Who's not getting PCI? Women, minorities, the uninsured, and folks in rural areas without access. And this paper really flips that on its head and says, well, who's getting too much PCI? Let's look at the other side of quality. And so in this paper, what they did is use the CAF PCI database from the NCDR and looked at those appropriateness criteria, and then looked to see at predictors of who was more likely to get an inappropriate PCI. So where is the overuse showing up in the data set? And interestingly, you might have predicted that if women and minorities and folks without insurance were just getting bad care, that they would have gotten more underuse and more overuse, just sort of not right care. Right. And instead, they saw that it was the exact opposite. So the people who were more likely to get overuse of PCI were insured white men in the suburbs. Okay. Which I think has some face validity if you think about sort of how these things work. But I think it takes a really interesting spin on this question because it points out that there are two very different, distinct pieces of quality that we're trying to address, right? We still have an underuse problem. We haven't fixed our underuse problem just because we have an overuse problem. It's different people. Right. So we have an underuse problem in cases where there may be an access issue, for example. We have an overuse problem in places where there's clearly not much of an access issue, but there's still a quality issue. And I think the interesting thing that this paper really made me think about as sort of a policy person is that if you try to put a policy in place that addresses one of these things, you may make the other one worse, right?
Yeah, that's true.
They're not the same problem. And so if you try to put a policy in place that really pushes hard on that overuse, well, what are you going to do to the underuse for the vulnerable populations who weren't getting it overused in the first place? Right. And on the flip side, if you really try to push on the underuse, what are you going to do to the overuse and the people who are already getting overused? So the thing that was really neat about this paper was just, I think that it really clearly set out the importance of understanding both sides of quality, sort of errors of commission and omission, if you will. Right. That you can't just look at a rate and know what that rate tells you. So when you look at the heat map of where the PCI rates are in the country, the ability to know which of those colors is correct is actually not totally straightforward. The lowest number is not necessarily the best number. The highest number is not necessarily the best number. Right. It's somewhere in between. And so research and then subsequently policies that really acknowledge just how thorny of a problem quality is and sort of figuring out the right time and the right place for the right treatment is much more complex than just do more or do less.
I mean, if they are a member of the PCI registry, one would think that this information comes to the hospital and this problem will get solved over time. But on a single center facility's agenda, what can they do to solve this problem? Will it just solve out over time as they keep getting more and more reports, or is something else needing to be done?
Well, I think that's a very interesting question. I think there are two fixes to each of these two quality problems, sort of a 2x2 table, if you will. There's a clinical fix and there's a policy fix. Okay. So the clinical fix to overuse is to provide feedback to clinicians at the time of service, so that as you sort of enter a patient's data into the registry, you're getting real-time feedback that starts to help you understand when a PCI might be very appropriate, when you might want to sort of think about other alternatives. The policy fix is largely happening in the reimbursement world. So we're seeing either private companies saying, we won't reimburse you for things that are inappropriate, or putting more financial risk on hospitals and health systems to try to find ways to trim expensive services. And if that's done right, the inappropriate stuff will be trimmed. On the underuse side, you also have a clinical fix. You've got people sort of putting in place care pathways and other ways where if someone shows up having a heart attack, there is a protocol in place to get them their PCI. And there's a policy fix of trying to report quality that is relevant to access to care. So I guess in my mind, it just really points out that there's not one fix, that we need both the policy world and the clinical world to be pushing on both sides of the appropriateness problem to make sure that we do sort of the right thing at the right time for the right patient.
Are you optimistic we'll solve this particular 2x2 problem?
Solve might be a little bit tough. I mean, I don't think we'll ever completely solve the problem. Some of the access problems are pretty difficult when you think about distance and access to care and obviously all of the insurance issues that are so salient right now. But I do think that things like this registry are putting quality and use sort of into the public discussion domain in a way that it's really never been before. And so I do think that it's going to get better. I think we're going to sort of right-size it in a lot of different ways. I just think it's going to take a little while to work out all the fixes. But yes, I definitely think it's going to get better.
Well, the pair of papers are in Jack, the original paper and then the commentary by Dr. Joynt. So please take a look at both of those because it's really a fascinating issue. For CardioSource World News, I'm Rick McGuire.